Almost 10 years ago, the Mental Health Commission of Canada was created to improve the treatment, medically and beyond, for those suffering from mental illness. The Commission has an enormous mandate, and Louise Bradley, its president and CEO, joins us now on what the Commission has accomplished and what is still to be done. It's nice to meet you.
Thank you, you as well.
Thanks for coming in today. All right, 10 years in business so far, so the first question, I guess, is kind of obvious. Do Canadians with mental illness have better care today than they did a decade ago?
That's a pretty big question. I think certainly the mental health landscape in the country has improved.
What does that mean?
Well, that means that there is still a long ways to go. One of the areas that the government gave us as our mandate was to look at the issue of stigma. That has improved, but it's still inhibiting people from getting the right kind of service at the right time and in the right way.
But there is way less stigma today.
Yes, there is.
That's fair to say.
I think as you know, we're seeing and hearing more about mental health than we ever have before. I'm appearing, many people are appearing on shows like this, talking about it openly, which is absolutely wonderful. But there are still people who fear that acknowledging that they have a problem might be a career-limiting move.
No, fair enough. But if you do acknowledge and if you do want help, are the services that are in place today dramatically better than they were a decade ago?
I'd really like to say yes, it is dramatically better, but I can't say that.
Why not?
Access to services is still an area that is really a big problem in Canada.
How come?
Worldwide, but in Canada. And I think that a lot of this is to do, again, with stigma, which prevents us from making the right investment. One of the signature documents of the Mental Health Commission is called a case for investment. And in that document, you will see that if we stay on the same trajectory that we are currently on, right now we are paying, it's costing Canada about $51 billion a year in mental health, lost productivity, disability claims, that sort of thing. If we stay going in the same direction, in 30 years' time, we're going to be talking about trillions of dollars.
Trillions of dollars?
Yes.
Annually?
Yes, that's right.
In lost productivity because of mental health issues?
That's right. That's right.
So we better get to it here.
Exactly. And so in talking about going forward work of the Commission, one of the areas that we will be focusing on are access to services. And
well, let me follow up on that, because
sure.
I know you're Canada, but we're Ontario, so we want to know how this province compares to the other 10 and the 3 territories. How does it?
Well, therein lies part of the problem. We're not able to really say that because we aren't collecting data in the same way in all 13 provinces and territories. So we'd like to be able to do that analysis and to be able to tell and show people how they're doing. So some places are doing better than others. I think the recent announcement that Ontario has made in terms of devoting resources to First Nations is absolutely phenomenal.
$222 million announcement.
Exactly, and about 40 of that will go to mental health related services, which I think is absolutely phenomenal.
You think that's a big deal?
I do think it's a very big deal. I think it's wonderful.
Part of your mission, I gather, also is to work on how to prevent mental illness in the first place.
Exactly.
How do you even do that?
Well, I think we have shown through the Commission things like school-based mental health programs. Targeting children and youth is certainly one way of doing that. And to everything from anti-stigma and discrimination efforts to children and youth, to looking at issues like children falling through the cracks when they become teenagers and go into the adult system. So there are so many things, and integration of services. Mental health is more than just a health issue. It's a housing issue, it's an education issue, it's even a justice issue. And looking at ways of integrating those services together and providing a broad-based service is certainly one way of doing that. In Canada, we still have a large group of people, psychologists, who only those with the right insurance or can afford to pay for it can have access to it. And these are people that are highly qualified, and yet they aren't part of our public system.
Let me follow up on the education angle, because, you know, did you go to university or college or something like that back in the day? Me too. Okay. Back then, no one talked about mental health issues. Now, the campuses are literally teeming with people who are suffering from the pressure of having to get good grades and graduate and so on and so forth.
Yeah.
So every time you, I don't know, it seems to me every time you think you make some progress on this issue, we find out about a whole new case of problems that we didn't even know about before. Can you get ahead of this thing?
I think so. I'm quite optimistic. The fact that we are talking about it and you're hearing about these cases doesn't mean that we're creating new problems. I think they were always there, but we simply didn't talk about it. I think it is different, of course, now with this generation in terms of social media, and there's a whole host of problems that you and I didn't have to think about when we were at university.
True enough. Okay, that's the post-secondary world. What about the workplace? Have you been able to make any strides in the workplace?
That I'm very happy to say we have made great strides. Canada is actually the only place in the world that has a psychological safety standard for the workplace. And it has really taken on a life of its own. And so we have private industry, we have governments, we have small, medium, and large businesses who have adopted this standard. And later on next fall, we will be releasing a 3-year study where we followed over 40 businesses and organizations who have adopted the standard. We're already seeing some of these businesses having a large reduction in absenteeism, disability claims, and staff morale improvement. Other countries are extremely interested and are looking at ways in which they can take the Canadian standard and adopt it for their own country. I think it's tremendous myself. It's transformational. Once upon a time, not that long ago, 5 years, we looked to go to mental health as something that you got, sometimes incognito, because you didn't want anybody to know you were going for help. And now to have mental health as part of your everyday workplace, where, by the way, we spend most of our waking hours, is absolutely tremendous. And now it still hasn't done away with stigma completely, but I think it's having a really significant impact. And so if we have people who are talking about it more at the workplace, maybe they'll be a little more willing to look at their children's problems, because we know a large percentage of people with kids that have mental health problems won't take them for help because of the stigma associated with it.
It just feels to me like stigma is something we've turned the corner on, and yet I hear you constantly referring to the fact that we're not there yet. How are we not there yet?
I think, the work that Bell is doing is absolutely phenomenal. I travel a great deal across this great country, and I'm still sitting next to somebody on the plane who finds out where I work. And each and every time there's a story, usually whispered. And so there is still, we're making great headway, but until we get to a point where mental health is looked upon in the same way as physical health.
Like breaking your leg.
Exactly.
You go get it treated.
Exactly.
We haven't talked about suicide yet. We have to. Despite the good news that you say we have, the advances that have come, and I appreciate you wanting to share that good news, I don't think you can pick up a paper in the country these days without reading about some suicide outbreak somewhere.
That's correct.
This is devastating. Why are we not making any progress on that?
Well, I think, the good news and the bad news is that the suicide rates in Canada have not changed in 10 years. It's totally unacceptable because for the most part, these are preventable deaths. Every day in Canada, 10 to 12 people die by suicide. And that still is not changing. And there are ways in which you look at Quebec has had a great deal of success. The program that they have implemented has seen a 20% reduction over 2 years. And so looking ahead, work of the Commission Suicide Prevention is definitely something that we can and want to be working on and plan to do so.
What's Quebec figured out that the rest of us have not yet figured out?
Well, you know, it's a little bit like the work that we've done in homelessness. The research project that the Commission did called At Home Chez Soi. I had people say to me, this isn't rocket science. You're trying to tell me that you had to study for 5 years, that putting somebody in a home is what works? Well, yes, we did, in fact, have to do that and have to show the evidence that it really does work. And that has also been hugely successful.
In asking this next question, I do not want to give any indication that I am somehow placing on some hierarchy, a non-Indigenous person's suicide compared to an Indigenous person's suicide. It's all terrible. But the reality is the outbreaks on reserves in particular have been nightmarish lately.
Yes.
And there's a difference in circumstances. And so I've got to ask whether or not you feel you have any better understanding of why these, in some respects, suicide pacts are made by young people on reserves. And if you do know, does that give you any extra insight into how to bring them to an end?
I would like to say I understand and I have a silver bullet that's going to fix this, but I don't. Now, if I was an Indigenous person living on a reserve, I think I would have a much better idea. And when we look at the Truth and Reconciliation Commission, the recommendations coming out of that, being acted upon, I'm pretty sure that that's where the answers lie. And I think we really need to look at, instead of focusing on just the one issue of suicide, it's all of the complex things that are bringing it to the rate that we are currently seeing.
It's true. It's all intertwined. There's no doubt about it. But the non-Indigenous world, when these things happen, seems to respond very quickly by flying people up. And, you know, they've got the crisis counselors that come in 3, 4, 5, 6 at a time, and they meet with people and they do their thing. And I don't want to take anything away from the good work that I'm sure they think they're doing, but then they leave.
Yeah.
And, you know, in some respects, you're back to square one. How do we get away from that?
Well, I think, you know, all of these things are done with the best of intentions. And as I have learned from my Indigenous colleagues, good intentions simply are not enough, and they often do not work. I think when we look at the basics in these communities, like housing, water, education, the gap between what's provided there and what's provided in the rest of Canada is huge. That gap has to be closed. And until it is closed, we will not see a change in suicide rates. And we need to listen to them, as you said, to parachute in and try to fix something that isn't for us to fix, I think adds to the problem. I worry that it does.
Let me ask you about a different controversy, and this has been particularly topical lately, doctor-assisted dying. And the notion, I mean, we're clearly in a position where we're not going to have a law covering all of the angles on doctor-assisted dying for all of the reasons we're all well aware about, the manhandling on the floor of the House and so on and so forth, and the June 6th deadline of the Supreme Court is not going to be met, and we are in a place right now where we're just not going to have a law covering all of this. C-14, the bill, which was under consideration, was tabled, but it did not include in the bill the right for people who are suffering from dire mental illness to take their own lives if they want to. Was that a mistake?
I can't say whether it was a mistake or not. I do think it is the right thing, however, that we take our time and look at this. To make a blanket statement that people with mental illnesses should never be considered, I think is probably not the right thing. To do that, we are judging and measuring one's pain and suffering. And to say that somebody with a mental illness does not suffer every bit as much as somebody with a physical illness is discriminatory in a way. But yet it's a very complex issue, and one that needs to have the time. So I'm glad the time is now being taken to look at it more closely and try to figure out how we can look at this. But I think it has to be looked at, but it has to be done with a great deal of thought, including talking to people with lived experience.
I'm reading between the lines here, okay? Let me see, because I appreciate someone in your position can't necessarily say what you want to say. So let me put it this way. You are concerned that there will be people who may be suffering from dire mental health issues, but it may be temporary. And your fear is that too many of these people are going to be killing themselves with the assistance of their doctors, even though they ought not to be, because maybe they can be helped. And there's no law right now that covers any of that. Did I sum it up okay?
I think that maybe you may have simplified it a little bit.
Well, that's what we do in journalism.
Yeah.
But okay, you complicate it up a bit for me then. Go ahead.
Right. I think that, to put in the proper safeguards has to happen. We don't want vulnerable people dying by accident. So it's a matter of putting in the appropriate safeguards, ensuring that people have, we talked earlier in this interview about access to services. It may be that through this process, somebody who feels that they cannot live any longer with the amount of suffering that they have are discovering that there is an option for them to consider. Or it may be that they've lived somewhere where they simply did not have access to the services that can be available. All of those things are extremely important to rule out before we ever get to the point where we are looking at somebody dying with the assistance of a medical team.
Okay, fair enough. Let me give you a real life example here. This is a young man who talked about his struggles with the Globe and Mail. And here's what he said. When I say giving access to the mentally ill, I'm not talking about someone who has a panic attack once every 2 years. I'm not talking about someone who has a tendency for melancholy when bad things go on in their life and they have a rough couple of months. I'm talking about refractory patients. That's the term I always use, refractory or treatment-resistant patients, the people whom modern science can't help. The amount of wonderful people I have in my life is, quite frankly, almost infinite. The reality is, as much as I love them, their words and support are, in fact, useless to me. I appreciate the sentiment, but it cannot fix me chemically. So we're talking about giving access to people who are, unfortunately, neurobiologically doomed. Adam Mayor Clayton, young man, talking about his struggles with mental illness. What's your reaction to his analysis of this situation?
I think that we have to look at, the competency of somebody, whether or not they have been, whether they have looked at all of the options and tried everything, that they are making an informed decision, that, hopefully they are looking at talking with their family and close others. And it may be, for some people, obviously we're losing 4,000 people a year in Canada by suicide. So there are people every single day that come to this conclusion.
But would you agree that there are people for whom there just is not a medical or scientific response to what they're suffering?
Today, yes, I would.
Today that is the case.
I think that there are some that it is refractory, and I think that's a very low number, but I do think that to really look carefully at has everything been tried is absolutely crucial, and that an appropriate assessment is done by at least 2 independent mental health practitioners, that there's a bit of a cooling off period to really think this through. There has to be a process that is clearly defined and informed by the variety of opinions.
I appreciate your position on this. You do know you're in the minority as far as Canadians go right now. And I only say that because Angus Reid did a poll in April, and they found 78% of those surveyed did not think that psychological suffering on its own was reason enough for doctor-assisted death. There appears still to be, you can tell me if I'm right or wrong on this, a divide in this country between between those who believe physical pain is legitimate enough reason to take your life versus psychological pain. Mm-hmm. Fair to say?
Yes. We at the Commission have consulted with a number of people. We have various advisory councils available to us, and you're absolutely right. there is a very divided opinion. Hence, the reason that we need to look at and consider all of these opinions before we ever get to a point where we legislate one way or the other. I'm just saying that at this point, I don't think we know enough, we've consulted enough, talked enough to say that it is one or the other.
Okay, here's Mark Hennick, mental health advocate, who wants to argue a different point here. He says someone with end-stage cancer may have gone through their full course of treatment and determined that nothing else can be done. But someone with a severe and persistent mental health problem likely didn't receive that kind of care at any point in their journey. And on top of that, mental illnesses attack your perception. They attack your ability to hope and to see changes in the future and to conceptualize your recovery. So that makes it difficult, he writes, to actually think you could lead a normal, whatever that means, and happy life in recovery. Mm-hmm. Does someone with a mental illness, therefore, have the mental capacity, in your view, to make the ultimate decision?
Certainly competency is a critical point. That is something that has to be assessed appropriately.
You think you can be competent and suffering from mental illness simultaneously and yet logically conclude, I want the right to die?
People with mental illnesses can be and are quite competent to look at all of the various options and to make a decision. I think it's the freedom to make decisions that we're looking at. But to a blanket statement and say, this never applies, then takes away from the first person that you read about.
Okay, fair enough. But you know, I guess part of the response to mental illness from the professionals is, let us work with you, this will get better. But if you allow people to take their own lives when they're suffering from mental illness, you are in essence throwing in the towel on that philosophy, aren't you?
No, I don't think.
No?
I mean, Mark makes a very good point in that I think the vast majority of people have not had access to the right services or any services in some cases. And that is a critical point. I agree with him completely on that. And that is one of the reasons why part of the process has to be to determine whether or not somebody has exhausted all of the various options. I think we're talking about a very small number, and certainly I, for one, would be in favor of trying every single alternative that we possibly can.
Louise, you and I are both boomers. And they say the boomers, you know, whenever the boomers change their mind about some cultural phenomenon, you know, the country soon follows, right? So more and more boomers are going to become seniors, they're going to retire, they're going to face presumably new and different mental health challenges as they go into the retirement years. Are we ready for this?
Probably not. Probably not. And I think that, you know, again, we have to look at the way in which we look at seniors. I think it's probably a dual stigmatization there. We look at somebody who is elderly and say, well, what do you expect? She's 85 years old. She has to be depressed. That's not the case. Just because somebody is a certain age doesn't mean that they automatically suffer in this way. And so I think that changing the attitudes and looking at how we treat seniors, looking at the needs of caregivers, is all various things that have to be looked at more closely.
Is this stat still accurate? 1 in 5 Canadians will suffer from some episode of mental health at some point in their lives?
That's correct.
20% of the public. Okay. You've had 10 years at this. You've got another 10-year mission now on the books. Mm-hmm. What's job one for the next 10 years?
It's 1 in 5 at any given time. Actually, by the time you reach the age of 40, 1 in 2 will have or have had a mental illness. And so I think when you look at other numbers, today there are 6.7 million people in Canada suffering from a mental illness. There are 2.2 suffering from type 2 diabetes and 1.4 with heart disease. If those numbers were reversed, I think we might be looking at things a little bit differently. So my hope and what we want to see at the Commission is that those numbers become more even and that mental illness and mental health issues are looked at in the same way as physical illnesses, because until then, we aren't going to look at it seriously enough. And sadly, we aren't going to make the investment. And Canada needs to invest more in mental health going forward.
Understood. That's Louise Bradley, Mental Health Commission of Canada. It's good of you to visit us at TVO tonight. Thanks so much.
Thank you. Delighted to be here.
Help TVO create a better world through the power of learning. Visit supporttvo.org and make a tax-deductible donation today.